This video will document the extended endonasal endoscopic resection of an intra and extradural clival chordoma. The patient presented with hyperreflexic lower extremities, bilateral sixth nerve palsies. We elected to do an endonasal endoscopic approach. ENT first opened up bilateral maxillary sinuses in order to store the nasoseptal flaps, and then harvested bilateral nasoseptal flaps due to the extensive nature of the expected deficit. A wide sphenoidotomy was performed, and the floor of the sphenoid sinus was removed to widely expose the retrosphenoidal clivus. The mucosa was completely removed, as the nasoseptal flaps will eventually be placed in this location and would cause a mucocele if there was any mucosa left behind. Extensive drilling of the clivus was then performed, starting just below the sella and extending down first to the bottom of the sphenoid sinus. The bone was completely removed between the carotid arteries. A kerosene was used to expose the inferior aspect of the sellar dura superiorly, and then laterally bone was removed just to the extent of the Dorello's canal and the medial aspect of the ICAs. The superior aspect of the tumor was dissected down to find its superior margin, and this was sharply dissected off the dura. The first half of the surgery was going to be a resection of the extradural tumor, which was extensive. The inferior extent of the tumor was reached by making a U-shaped flap between the eustachian tubes and taking down the basopharyngeal fascia over the tip of the odontoid and the anterior ring of C1. The tip of the odontoid was drilled down in order to provide adequate exposure to the inferior aspect of the tumor. This U-shaped flap will be stored lower in the nasopharynx and can be brought up at the end of the operation during the closure. The extradural tumor inferiorly and laterally was then debulked internally. Frozen and permanent sections were sent to pathology, and then the Nicomyriad device was used to internally debulk the tumor. The lateral extent of the tumor was rolled out from behind the rectus muscles. This was done on the left side first, and then on the right side. By rolling out the tumor, we tried to preserve the external capsule of the tumor to ensure a gross total resection. The scope was held by an endoscope holder with constant irrigation for visualization. Once the right lateral extent of the tumor was removed, it was sharply dissected from the dura and internally debulked with the Nicomyriad device. And then the left lateral extent of the tumor was rolled out from behind the muscle to ensure a complete resection of the lateral extradural extent of this tumor, which was extending slightly behind the eustachian tubes as well. This was done with careful bimanual traction, counter-traction, using straight and angled instruments. The dura can be seen. Once the first stage was done, it was clear that where the location was of significant intradural tumor extending slightly more inferiorly. Therefore, on the second stage, done approximately 2 days later, the patient was brought back for additional drilling of the anterior ring of C1, the tip of the odontoid, and the bone of the condyles. The dura was widely opened, fluorescein stained CSF can be seen. Both vertebral arteries were carefully dissected free from tumor. Once the tumor was dissected away from the vertebral arteries, the NICO could be used to debulk the tumor. The tumor was somewhat stuck, not only to the vertebral arteries, but the pons and medulla, and this had to be sharply dissected in order to avoid damaging any of the vasculature or interrupting the peel margin of the brainstem. The tumor was mobilized inferiorly below both vertebral arteries, and then once again debulked. The inferior aspect of the tumor, extending just behind the dens, was mobilized and again debulked down to the inferior aspect of the dura until there was no obvious residual tumor, except for a slight bit lateral to the vertebral artery, which was removed with angled instruments. The closure was performed with an inlay of duraform, and then, given the lack of bone, a button closure with 2 layers of alloderm were placed as an inlay-onlay graft. This was covered with a piece of fat and a vascularized nasal septal flap, which had been harvested bilaterally, was used for a final layer of closure. This was held in place with adherus, and the nasal cavity was filled with flow seal, and finally nasopore was placed to buttress. A gross total resection of the tumor was achieved.